to medical social control. Welcome to medical social control in the COVID-19 era. So good morning, good afternoon, good evening. Hosted the session. I will be chairing the session, facilitating the discussion, later on the Q&A, and it's been hosted by the Canadian Sociological Association in the context of the Humanities and Social Sciences annual conference here in Canada, Congress 2023. So as we always do in Canada in formal gatherings, I'm going to read a version of the land acknowledgement, and then we will proceed. While we meet here on a virtual platform, we should take a moment to recognize the importance of the land on which we are each located. We, in Canada, acknowledge the territory to reaffirm our commitment and responsibility in building positive relations between nations and in developing a deep understanding of Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, First Nations, and Métis peoples. So I'm the moderator, chair, and sort of the organizer of the session. My name is Claudia Chauffin. I'm a sociologist, as pertinent to a sociological association hosted a webinar. I'm also a medical doctor. In my past life, I was actually practicing medicine. I'm currently at York University as a professor of health policy and global health. So some technical tips that I hope you'll be able to grasp better than I generally do. Move your cursor to the toolbar at the bottom of the Zoom window. Click on closed captions or live transcripts if you want to see that. To enlarge the font, click on caption settings. And please enter your questions through the Q&A, and then I will read them and we will hopefully have an interesting conversation. You may use your name or ask your question anonymously, however you feel more comfortable. So what to expect? We will first hear from Sydney Chapados. Sydney will talk about discourses of contagion. Then Agnes MacDonald will tell us about the Semmelweis hypothesis. Pierce Robinson will continue with malinformation and the COVID-19 infodemic, quote unquote. He'll have a lot to say about that. And then Manuel Ballet will talk about ideological tactics to boost uptake of experimental treatments, and then a Q&A. So let's start with Sydney Chapados from Carleton University. Sydney will present on homelessness, COVID-19, and discourses of contagion. She's a PhD student at Carleton University in Ottawa, Ontario, who researches anti-poverty programs and policies in Canada with an explicit focus on how childhood is represented, conceptualized, and mobilized throughout these initiatives. So please, Sydney, take it away.
Absolutely. Let me just share my screen. Okay, so thanks so much for being here today. So my name is Sydney Chapados. I am a PhD student at Carleton University in Ottawa in Canada. And I'm going to talk a little bit today about some work that I did with the Algonquin College Victimology Research Center. So just what we're going to go through today. So I'll talk a little bit about the project, how we conducted our data, where the information is coming from. I'll explain the Ottawa context, what Ottawa did to try to curb the spread of COVID-19. I will introduce our theoretical concept, which is coming out of Robert Crawford's work on the self and the unhealthy other. And then I'll go through three thematic results that we uncovered, which was identity work, the way that the risk of COVID-19 was presented as an individual risk, and some of the dehumanizing responses that people had to endure throughout the COVID-19 pandemic here in Ottawa. And then I'll just conclude by giving some quick takeaways, some kind of key messages of this work. So this project was conducted as a partnership with the Alliance to End Homelessness Ottawa and the Victimology Research Center at Algonquin College here in Ottawa. And we were just really broadly asking this question of how the COVID-19 pandemic impacted service provision within homelessness serving organizations in Ottawa. We were paying attention to the adaptations and challenges in service provision. So looking at things that maybe worked out really well for services, things that maybe were better than before, but also things that got really hard during COVID-19. So to do this work, we did interviews, pretty long interviews with 20 service providers, 8 key informants who had broad cross-sector knowledge. And we did a media scan to look at some of the discourses that the media was using when talking about COVID-19 and homelessness. There's also an additional phase of this research that's underway right now that involves interviews and focus groups with people with lived experience of homelessness throughout COVID. So this presentation today is talking about one critical emergent theme that came out of this research, which is risk, the way that people were negotiating the risk of COVID-19, and contagion, the way that contagion discourses were applied to people experiencing homelessness pandemic. So it's really important, just before we get started, I just want to say that this conversation requires a lot of nuance because the way that people were impacted by COVID-19 is extremely varied, and I absolutely cannot capture it in a 15-minute conversation. So it's very important that I'm letting these stories kind of speak for themselves, not trying to slot them into any narrow political purpose, but just thinking about how can we make responses, or how can we make a world that is more just and more accessible for all people. And so that said, it's really important to pay attention to the social, cultural, and historical context of homelessness in Canada, that where people who experience homelessness have been historically and are presently neglected by distinct patterns of disinvestment, criminalization, confinement, and medicalization that has led to a significant lack of trust, significant and justified lack of trust. And throughout the pandemic, a lot of people were left feeling that there was just no good choice and no good outcome of this, and that this was a lose-lose situation for a lot of people. So that said, pretty much immediately when COVID-19 was declared a pandemic, congregate living environments such as jails, shelters, long-term care homes were identified as high-risk settings. So public health jumped on that right away, started doing sentinel surveillance and hotel isolation for people who were staying in shelters. So what this looked like was public health doing symptom screening and testing for people who were staying at shelters. And if people were symptomatic or if people were tested positive, that they would be isolated in a hotel. Shelters also did their own measures, such as physical distancing, the enforcement of PPE, symptom screening, added capacity limits. So, cutting capacity by 50%. Added cleaning protocols. Some places cut their hours, some places switched to virtual service provision, some places closed their doors altogether. Unfortunately, despite these measures that were put in place to try to stop the spread of COVID-19 in shelters, in January 2021, 4 of Ottawa's major shelters entered outbreaks, causing them to close their doors. So you can just think for a second about what might happen when 4 of the major institutions that people rely on for housing and for food close their doors. So people were essentially left alone to navigate a bunch of new rules about public space. Where am I allowed to be? Am I allowed to be in a park? Am I allowed to be in this neighborhood? Where am I allowed to be? When am I allowed to be there? What information can I trust? Left alone with it. And asking this really important question, which is how can I follow a stay-at-home order when I don't have a home to stay in? Or how can I shelter in place when there is no shelter for me? And so this question really was integral to the work that we did. How can people be expected to follow a stay-at-home order when there is no home for them to stay in? So we framed our project using very broadly Goffman's 1963 theory of stigma. So for Goffman, stigma is the process where attributes or behaviors are discredited as abnormal, deviant, and dangerous. Because of this discreditation, the general public rejects people who possess those attributes or behaviors, and that leads to a spoiled identity where the entirety of the person is devalued, right? So it's not just certain attributes or certain behaviors that are devalued, but the whole person becomes devalued as a consequence of these attributes or these behaviors. We then furthered this concept of stigma just a little bit by using Robert Crawford's work on the HIV/AIDS pandemic, where he argued that health is a critical component of stigmatization. So one's concept of themselves as healthy or unhealthy is really critical to stigma. And he connects this to a self-responsibilizing political and social environment where health is viewed as an individual responsibility. So people who are healthy or who have that healthy status are seen as good citizens who have made the right choices to manage their health properly, where people who are unhealthy are blamed for not properly safeguarding against disease, even though it's not their fault. So the healthy separate themselves from the other or from the unhealthy to protect their identity as good citizens. And so what this is more than just a fear of the spread of a virus or the spread of disease, but also the fear of identity dissolution, right? So the fear of being associated with someone who is considered a bad citizen, or the fear of becoming unhealthy ourselves and losing our status as a good citizen. And so contagion, this passing of virus from one to the other, really threatens that boundary between the healthy and the unhealthy, and it disrupts this idea that health is connected to our choices, because anybody can become unhealthy. And this is also, again, really important to pay attention to the political context. So people who face structural oppression are more likely to experience worsened health outcomes. But despite the fact that this is structural, individuals are made to shoulder the blame. So individual people take on the blame for these broader structures. And so I've pulled a quote from Tyler here that really exemplifies the way that we approach stigma. Because while stigma is often an individual experience, so it's experienced through looks, comments, slights, remarks, and face-to-face encounters, it is always enmeshed with wider structures of expropriation, domination, discipline, and social control. So people experiencing homelessness were already stigmatized long before the pandemic. They were assumed to be both behaviorally risky and vulnerable due to previous health problems. And they took on the dual weight of blame for both their housing status or for being homeless, as well as blame for COVID-19 and spreading COVID. So we pulled out 3 themes. Identity work. So we found that there was a significant amount of identity work going on in COVID-19 of this kind of I'm healthy, you're unhealthy, stay away from me type of separation that's going on. The way that risks for spreading COVID was presented as an individual responsibility. So individuals were taking on the risk, and the unfair responses and dehumanizing responses that people who were homeless went through during COVID-19 as a result of their treatment as risky and as bad citizens. So contagion stigma was applied to people who were already marked as incapable of managing their own health. So people experiencing homelessness were treated as a threat to the rest of society instead of themselves vulnerable to the social, economic, and physical disruption that happened as a result of COVID-19. This marking as being incapable of managing their own health, as well as service closures, saw a lot of people who were experiencing homelessness in public space, right? At a time where being in public space was really strictly regulated, and at times where it was also illegal. And so this led to a lot of debates about who had a right to be where, who's allowed to be in public space, and when. And this also led to the verbal and public mistreatment of people who were accessing services in public. So we heard from people who were being yelled at and sworn at in the street because they were accessing services. We heard from people who, were denied service at things like coffee shops because people knew that they were accessing services or that they worked in services. And so people were treated as if they were dangerous, that they were carrying the virus from these unhealthy spaces into the healthy spaces. And so that separation between the healthy and the unhealthy was verbalized. We also heard from people who not just experienced this kind of public mistreatment, but also relationship breakdown within their own communities, right? So friends and family who chose to stay away from their friends and their family members, or who chose to not associate with people. So no, you can't sleep on my couch anymore. No, we can't have dinner this week. because I need to protect myself. So again, we see this overall relationship breakdown, this interpersonal separation happening. And this is all kind of this boundary between healthy and unhealthy, which led to a giant loss of social support for people who were homeless during the pandemic. We also saw the individualization of risk, right? So where the risk for preventing COVID-19 was treated as an individual responsibility instead of a collective one. So pretty much right away, shelters spread. The spread of COVID-19 within shelters was presented as something that was inevitable, unavoidable. It's just the way things are that it's going to happen. And so people were left making this choice. Do I stay in shelter? Do I risk getting COVID-19 in shelter? Or do I sleep outside and face extreme weather? Or do I sleep outside and face violence? So people were left, trying to negotiate these risks, but it's not a simple trade-off. It's not easy to curb the risk of COVID-19, but then take on other risks at the same time. And so shelters, we know, are not built to prevent this type of spread. They're just not. People are sleeping very, very close together. Still, despite that infrastructural problem, individuals really internalize the blame for COVID. So we heard from people who really took that weight on, felt that they themselves had caused the pandemic. And this is a result of continuous messaging saying that people experiencing homelessness were a threat. We also heard from people who, because of that weight, tried to avoid COVID by taking alternative cures, right? So again, trying to negotiate the risk of COVID by exposing ourselves to significant other risks. So it's really just not a simple trade-off. A lot of people felt that there just wasn't a good choice, right? So negotiating risks meant that people had to negotiate a very complex nexus of risks. And then finally, because of the way that people experiencing homelessness were presented as incapable of managing their own health and less than human and dehumanized, a lot of unfair treatment was justified against them under the guise of saying that they require strict regulation, right? So there was a lack of trust for their ability to make the correct choices and to manage their own health. And so they experienced pretty intense measures, such as being locked up in a hotel or like all types of different really strict regulations that they had experienced. And so that were applied differently than they were to the rest of the population, and they were often done without providing full information, right? So people didn't really know why they were being locked up or why they were being sent away or why they were being moved out of spaces that were safe for them. So the measures that were put in place to try to contain COVID-19 actually ended up making people experiencing homelessness unsafe in other ways. And so a lot of people, were afraid of being institutionalized, especially people with histories of being institutionalized. And that caused a breakdown of trust between services and service users. Another thing that we heard from people who are homeless and these services was that there is reduced end of life care. So things like hospices were closed. And so people with fears of dying alone, complex fears of dying alone, unfortunately, those fears were compounded because people were not able to access that end of life care, and they were denied a dignified death as a result. So we heard from service providers who said that this was one of the hardest things that they had to deal with, was canceling those types of end of life services, because they knew just how dehumanizing that was for their service users. So just to sum up, people who are homeless experience stigma, isolation, and exclusion long before the pandemic. People experiencing homelessness were treated throughout the pandemic as if they were already carrying the virus and posing a threat, right? So they were already treated as if they were contagious. Public health measures emphasized personal responsibility for following COVID-19 regulations instead of collective responsibility, even when these were entirely inaccessible for people without a home. And ultimately, the measures that were put in place to curb COVID-19 could not address the most significant risk factor facing people who were homeless, which was the absence of a safe and secure home. So the key takeaways for this project are that people who were homeless during COVID-19 lost significant control and autonomy, faced violence, and missed out on community support as a result of the way that these measures were applied. The blanket measures, the expectation that every citizen can act the exact same way, did not address the unique circumstances of people's lives, right? And so that led to a lot of increased shame and blame when people were not able to follow those rules. So what we propose is that creating emergency responses in consultation with people who have these lived experiences. So people who have lived experiences of being criminalized or of being medicalized or of being institutionalized can provide more compassionate responses that can minimize harm and dissolve this boundary between us and them. And so we've published 2 articles on this research. So the first one is specifically about the discourses of contagion. It pulls out a little bit more, provides some examples of the way that the media was discussing people. And then the second article there is just kind of a general overview of our results that we came up with in the project. So yeah, thanks so much for listening.
Thank you very much, Sydney. Fascinating research, and I look forward to reading some of your work. Thank you so much. So we're going to move on, and then we'll have time to ask everybody questions about their work to the Semmelweis hypothesis, lessons about hygiene in the age of COVID-19. And I trust that we'll find significant overlaps with the work of Sydney. This is by Agnes MacDonald, Simon Fraser University, lecturer in the Department of Sociology and Anthropology. This is in British Columbia, for those who may not be located in Canada. She researches social theory of the 20th century, late modernism, with a Central European concentration. So welcome, Agnes, and take it away.
Thank you so much, Claudia, and thank you, Sydney. That was super interesting topic and field research. My topic is quite different. It's socio-historical documentation about hygiene. So the title of my work is the Semmelweis hypothesis: lessons about hygiene in the age of COVID-19. I'm going to read my paper. It's a discussion. I'm trying out ideas that I was researching, and this is sort of the first stab at it, the first take at it, with a bit of a personal twist on it, personal experience, and data and theory combination. So hopefully it's interesting enough. I appreciate your attention. During the past 3 years, guarding against the spread of the variations of the COVID-19 virus by hand washing according to the scientifically designed modes and using hand sanitizers after touching anything or anyone had become an imperative. The dominant values about what is considered clean, sanitary, and sterile today are contextualized in science in such a way that only those of us, people, are considered civilized, educated, and reformed, who sacrifice ourselves to save the other from this virus by the ritualized practice of hand washing and cleaning. In this paper, I argue that the COVID-19 era has usurped cleaning and hygiene narratives for medical social control, which in turn present themselves as the organizing principles for societal expectations to construct a dichotomy of us versus the other, where the other can be excluded from participating in or contributing to society. Exclusion of ordinary people from society in this case ought to be seen as hyperbolic and very damaging for the person and society. The institutional reproduction of disinfection for the prevention of transmitting COVID-19 viruses in every sphere of our lives works only if it is carried out in properly procedural manner. Otherwise, it is ineffective. I trace the origins of Hungarian.
Agnes, we're having a little trouble hearing you.
Oh, okay.
We didn't hear whatever you said a minute ago.
Oh, no. Oh, I'm so sorry. Can you hear me now at all?
Yes, yes, now yes. You lay out your thesis. At least I heard it until then.
Okay, well, should I continue from, I
Yeah,
argue that.
Go ahead,
Okay.
go ahead. Yeah, go ahead.
All right, I'm so sorry about that.
No, that's fine. Your image froze, that's all. Yeah.
Okay. The institutional reproduction of disinfection for the prevention of transmitting COVID-19 viruses in every sphere of our lives works only if it is carried out in properly procedural manner, otherwise it is ineffective. In an effort to demonstrate how clinical hand washing had become effective, I traced the origins of this important procedural manner of modern medicine's practice of hand washing as a hygienic measure of transmission prevention by highlighting Hungarian obstetrician Ignaz Semmelweis, who lived from 1818 until 1865, and his discovery, which was over 150 years ago, of necessary disinfecting. To tell the truth, I am not against hand washing. I believe in clean hands. In fact, when I was a teenager, one of my OCD rituals was very frequent hand washing. Furthermore, for a long time now, it has been my habit to use paper towels or Kleenex to touch public door handles, wear my winter gloves on public transportation as long as I can without looking like an idiot, and designating fingers to touch certain public surfaces such as bank machine keys. When I enter my home from being away, the first thing I do is, in fact, wash my hands. And this list can go on. I don't want to bore you with that. But I don't do these things because of my fear of the COVID-19 virus. I have always done really proper hand washing. The problem, what I see, is with the mandated hand washing, underlining mandated narratives to protect us and others from the COVID-19 viruses. Thus, I'm against excluding any members of society based on questionable premises of scientifically claimed narratives. Personally, I have been forced to use hand sanitizers upon entering shops, restaurants, medical facilities, and the like during the past 3 years, or be excluded, disallowed to enter them, and that I have also experienced. So how did hand hygiene become an important prevention measure of the SARS-CoV-2 disease around the globe from the start? The World Health Organization spearheaded the narrative of hand washing, which was already established by the Global Hand Washing Day on October 15, 2008. Washing and sanitizing our hands as frequently as possible and in a scientifically determined fashion in every space and circumstance have become the mantra of safety against the COVID-19 virus. In fact, there are endless articles on the internet and signs in public washrooms about hand washing. Therefore, it is superfluous for me for listing them here. I think most of you are familiar with what I'm referring to here. Quoting from Potali and Korvalich's study, they explain that the recommended strategy for keeping pathogens at bay is to wash our hands as a basic preventative action carried out by the majority, since our transient skin flora have an important role in the transmission of pathogens. Worldwide, public hand washing facilities have been established, particularly for the inclusion of homeless populations to access amenities for disease control. Ministers and public figures with authority to speak to the dangers of COVID-19 frequently demonstrated proper hand hygiene by the use of hand sanitizers during their appearance in the media. We've seen YouTubes of that, I think, plenty. While my paper is not arguing against hand washing as a way to maintain clean and hygienic surroundings and avoid contamination, it aims to advance knowledge about the origins of hand washing, cleaning, and hygiene, and in turn to debunk the mandated hand washing narratives. But it is still in a very early stage of my research and developing my argument. So hopefully I will get to some sort of a point with it. Let me start with a bit of ancient history here. Water has been the basic element of cleaning and hygiene from ancient times. In a recent article, Angelakis in 2020 and his co-writers explain that already in the early third millennium of the Bronze Age, Bathrooms, toilets, drainage, sewage, and water supply networks were put in place in Mino and Crete. In fact, archaeological studies indicate that the first rural settlements from Egypt to Asia had a variety of water supplies for cleaning, sanitation, and religious ceremonies. Classical Greece is recognized as the birthplace of modern medicine, but even before Hippocrates, born and lived between 460 and 377 before the current era. So Hippocrates, named after the god Asclepius, the son of Apollo, healing and medicine were practiced in a sanctuary called Asclepia. I'm not sure if I'm pronouncing it properly in ancient Greek. And in the Homeric times, this was already taking place. Asclepius' medicine included the use of water and baths for therapeutic, hygienic, and religious ceremonial purposes, sourced from wells, aquifers, natural springs, rivers, and flowing torrents. The word hygiene or hygiene originates from Hygeia, if I'm pronouncing it correctly, one of Asclepius' 3 daughters, who was also the Hellenic goddess of health. Therefore, hygiene was established as a branch of medicine. By the 5th century, before the current era, when Hippocrates was practicing medicine, over 400 Asclepia were functioning to heal the citizens of the Hellenic Empire, with Epidaurus being the central sanctuary. The Hellenic healing and cleaning methods were adopted by the Romans. For example, Asclepiads of Bithynia established medicine and the importance of washing surgical tools properly already in around 100 before the current era. Aqueducts built across the vast Roman Empire ensured availability of clean water for all. In sum, the ancient classical era established the foundations of modern medicine and the crucial role of water for therapy and hygiene. Basic sanitation technologies and the importance of hygiene for health, therefore, is not a new thing. So why does it seem that we have just invented a new science of clean to prevent the spread of COVID-19? Let me trace a bit further the history of water and cleaning in order to see linkages and contradictions of our contemporary mandate for hygiene. So thus, with the waning of antique Greece and the fall of Roman Empire, Christianity ushered in the gospel about the purity of the soul. Jesus washed his followers' dirty feet, touched the lepers, and ate with unwashed hands. He did not care about cleanliness for the sake of hygiene. The body became unimportant for a true Christian. Medieval homes did not have running water, therefore, anatomically shaped toilet seats and sewage systems like the Greeks and Romans did. Bathing and caring for one's body had become an unholy practice in exchange for the soul's cleanliness. Hand washing, cleanliness, and table etiquette were said to be repulsive. In fact, this was a time when sanitation was deplorable, although soap existed, but was rarely used. Furthermore, poor hygiene was not restricted to the lower classes. Extremely wealthy were regarded as nasty and hideous. This is not to say that people did not wash themselves. As Joanna Burke describes in her article, public bathing became extremely popular in Europe from the 9th to the 16th century of current era, with many of these places serving as brothels as well, while the royal and aristocratic company enjoyed bath parties as an element of diplomacy. But the bubonic plague had put an end to public bathhouses from the mid-1300s in most parts of Europe, taking the first hit of blame for the rapid spread of the disease. Ironically, it was in dirty people's unwashed clothes where the bacillus-carrying fleas were actually harboring most. The Black Plague had been barely eliminated, and the public returned to the habitual visits to public bathhouses. When syphilis became the next killer, once again, bathhouses were blamed for the spread of immorality, and the deadly and disfiguring virus, claiming victims in huge numbers. By the early 1800s, water evaporated into gas in a way because the so-called miasma or miasma, not sure which one is the most correct pronunciation, diseases emanating filthy air was considered to threaten the health of urban populations, especially in poorest neighborhoods of growing cities. To this effect, one of the first class wars began between the poor and the wealthy, the proletariat and the bourgeoisie across Britain and the industrial metropolitan areas of Europe, based on arguments that the well-off hygienic people could catch the illness harbored by the lower classes. So entered the Victorian era's compulsion of public sanitation, targeting the cleanup of the homes of the poor, packaged in the rhetoric of moral panic, and aided by the respectable public figures and authors such as Thomas Carlyle, Charles Dickens. Yet medicine was in its infancy, and linking pathogens to infections discovery was waiting to be made. As again, Pottley and Carvelich argue in their most recent article from 2022, in the 1800s, hand washing was not medical common sense. It was, in fact, considered outrageous until finally epidemiology and the newly established institutions of public health offices gave authority to construct new domestic standards of cleanliness for everyone to follow and protect against contagious microorganisms. Therefore, the basis of contemporary fear of germs can be found in the late 19th century epidemiological discoveries, contagion, and subsequent efforts of eliminating germs and viruses with the cleaning products in both public and private places were put in practice. Mass industrial production in Europe and in North America was partnered with the novel academic disciplines of sociology, psychology, marketing, and advertising to construct and study and offer solutions to the fears about miasma-caused contaminations. Hence, the moral and physical effects of cleanliness was introduced. Again, as Burke argues, it was women, particularly housewives in the US, who were targeted as the most appropriate audience and consumers for the newly marketed products of soaps and cleaning products for the body and household in the late 1800s, early 1900s. In 1927, the Cleanliness Institute was established by the Association of American Soap and Glycerin Producers with the aim of imposing hygienic regimes on Americans, where cleanliness now entails a systemic education and control of the body. So the cleaning is a never-ending project with ever-shifting goals. The prevention against the COVID-19 virus by hand cleaning is one of these shifting goals. But these goals maybe are not part of this paper's discussion right now. However, I would like to draw attention to a key figure in establishing the system of hand washing hygiene for contemporary medicine and public health. His name is Ignaz Semmelweis. He was a Hungarian obstetrician. I grew up in Budapest. In fact, right now I'm in Budapest. In fact, I grew up on the Buda side, near where Semmelweis was also born and lived. Semmelweis's name is a household name in Hungary amongst Hungarians. He's extremely well known in any circles, basically. The prestigious University of Medicine in Hungary is named after him, Semmelweis Medical University. And in fact, there are metro stations and street names named after Semmelweis. And I just went to the museum named Semmelweis Museum that was kind of constructed out of his home, his birth home. So that's actually a pretty interesting experience. This is a little booklet I picked up at the museum, which was really well organized to describe his life and work and effort in medicine. So his context is the mid-1800s, where puerperal childbed fever was very pronounced as one of the main killers of mostly women who were giving birth. About 40% in parts of Europe in fact, is known by now to be caused by A and B streptococcus, which at that time was quite a mystery in the medical community. This germ was actually known to originate in the 16th century. However, for hundreds of years, it was not recognized by the medical community, and hence no prevention or treatment against it beside the traditional bloodletting and other kind of traditional ways was used. In their article, Tyagi and Barwal explained that epidemically, puerperal fever was considered to be caused by the so-called miasma, and in lay terms by the will of providence. Women gave birth at home until the early 1800s, when hospitals opened in large cities to medically assist the growing populations who were working at various industry sites in urban centers. Thus, women were also encouraged to use these hospitals to give birth in a so-called safer environment with the aid of physicians and nurses and science. Hospitals then yielded the opportunity to not only treat illnesses, the injured, and help babies come to this world, but also to serve as laboratories for testing and studying illnesses on the deceased. Indeed, autopsies have become a large part of physicians' training into symptom-based diagnosis. A scholar suggests in their article, in 1823 is the year that marked the beginning of pathological anatomy or autopsies. For instance, in the Vienna General Hospital, which was also the year when childbed fever began to skyrocket. Performing autopsies was a dirty business. Physicians' white lab coats appeared stained by blood and body fluids from the cadavers, which paradoxically gave them all the more cachet, being revered as scientists. These doctors in the hospitals were always busy. They frequently were going from patients to patients without wiping their hands, from cadavers to patients without washing, cleaning themselves, changing gowns, and so forth. And unknowingly, they were transferring deadly streptococcus bacteria from the cadavers to the bleeding mothers during the delivery of their babies. While most doctors did not have the time or interest to research the causes behind childbed fever, a few were keen to investigate because numbers were really skyrocketing. It became a very serious issue. One of the first medical scientists who paid attention to it was Oliver Wendell Holmes, who published an article in the early 1840s in the New England Quarterly Journal of Medicine and Surgery, entitled "The Contagiousness of Puerperal Fever." It is not clear whether my research subject, Ines Semmelweis, had read Wendell Holmes's article or recognized the same idea at the same time. To disinfect hands would be necessary, is the claim of Wendell Holmes as well as Semmelweis's. So Semmelweis began practicing medicine at the Vienna General Hospital's maternity clinic #1 in 1846. Early on, he had observed the high death rate of mothers due to childbed fever, while in the adjacent wing in Clinic 2, which was run by nuns and midwives, the number of deaths for mothers after childbirth was insignificant in comparison, less than 7%, while in the #1 clinic, it was up to 15%.
Agnes,
yes?
I'm sorry to interrupt you. It's a fascinating story, but we're going to have to wrap up. We're
okay,
well below
right,
yes. time.
Okay.
I was trying to signal you, but I was muted. I didn't realize that.
Oh, no worries. Okay.
So maybe the takeaway lessons, so we can move to the next presenter.
Yes, I will. Okay. The takeaway lesson is that indisputably, hand washing remains the most reliable practice for the prevention of contagious matters such as the spread of COVID-19. Today, in connection with the coronavirus pandemic management, the idea of hand hygiene plays a central role. Drawing on Martini and Lip's position, I argue that to make it work well, however, it must be done properly with soap and water and this famous chlorine solution that Semmelweis invented. And what needs to be recognized parallel with the mantra of practice of proper hand hygiene is the underlying rhetoric of medical social control, which has become out of control. The lessons from Semmelweis's hand washing hypothesis is the lesson of common sense. By turning the imperative for hygiene on its head, I consider Ignaz Semmelweis's contribution to medical research and his very sad life story, since he was beaten to death for his insistence on hand washing, that we can take it as a sociological biography of lessons about hand hygiene and hygiene in our age of the fear of viruses from a rear view mirror. Thank you so much.
Thank you very much, Agnes. I think that peers will be able to pick up on some of the issues about communicating the kind of information. So that's a good transition. So we're going to hear now a presentation by Piers Robinson, a political scientist, co-director of the Organization for Propaganda Studies, co-editor of Propaganda in Focus, and convener of the Working Group on Syria, Propaganda and Media. And it's actually longer than that. There's other items that I left out because of the space, but Piers maybe wants to discuss them. He has served on the boards of several academic journals, as well as is professor of chair in politics, society and political journalism, Sheffield University, 2016 to 2019. And so welcome, Piers, and the floor is yours.
Hi, thank you very much. I'll share my screen and then get underway. Right, where do we go? I think I'm sharing the wrong screen there. Let me just bring there we go. Is that showing okay now?
Yes, it is to me, hopefully to others as well.
Okay, if it isn't, just send me a signal and I'll
Sure.
go back, but I'm
Sure.
actually okay. Okay, today I'm just going to offer a critique of the infodemic crisis. And without further ado, I'll go straight into the presentation. The infodemic crisis, or the infodemic panic, is arguably dominating political and also academic circles at this point in time. You can see a few pictures up there. We can see one is the Verified project initiated by the United Nations, aiming to fight misinformation during COVID-19. The other slide showed the World Health Organization, which issued a campaign asking people to report on what they perceive to be misinformation. But there is this crisis, this sense in which misinformation, information which is inaccurate and which is circulating, disinformation, which is essentially information which somebody is distributing in order to deliberately deceive, to engage in deception, essentially, and also malinformation, which is notionally accurate, truthful information, but which might serve to undermine trust in authorities. There is a great concern at all political levels and across academia that this problem is essentially a crisis, an infodemic that we have at this point in time. Now, this narrative, which has really been developing in particular since the 2016 election in the US, when the fake news crisis kicked off, this concern over misinformation and disinformation, in particular during COVID-19, has, perhaps ironically, occurred alongside what we now know to be very substantial propaganda drives to promote official narratives. So whilst a sense of crisis has been emphasized about misinformation out there amongst the public and so on, this has been occurring at the same time as authorities have engaged in major propaganda drives. You can see in the picture there NHS poster, which was used in the United Kingdom, employing sort of shame, etc., in order to push people to comply with the restrictions which were being used. We also know now that there was formal censorship via broadcast regulators in multiple countries. There were informal agreements between big tech and authorities in order to censor information. There were also smear campaigns, and we'll see an example of this in a few minutes. There were smear campaigns initiated against scientists who questioned authorities during COVID-19. And there was also a context of coercion during COVID-19, whereby people who were not, as it were, complying with various mandates ran the risk of losing employment and so on and so forth. So this crisis over misinformation, disinformation, malinformation has run hand in hand with what are, I would argue, increasingly well-documented propaganda campaigns emanating from authorities during COVID-19. Now, I would argue that the level of activity and the intensity of organization surrounding the management of information during COVID-19 looks to me to be unprecedented, and this is coming from somebody with a political communication background. The slide that I put up here, forgive me, it's obviously a lot of detail in there, and you don't need to sort of take a long look at it now, but essentially what you're looking at there is the information which has emerged from the Twitter files, which were released in the autumn of 2022, and journalists such as Andrew Loewenthal, Matt Taibbi, Michael Schellenberger have been going through the Twitter files. What they have found is an extensive network of foundations, big tech fact checkers, think tanks, academic initiatives, and government entities involved in the active censorship of information during COVID-19. And they're describing this as the censorship industrial complex. So it's becoming transparent now that what we could see, say, a few years ago and say, well, there's clearly a big propaganda drive surrounding COVID-19 to promote public fear of the virus and also to promote compliance with various restrictions. It's now emerging this was highly organized, and there are other areas of inquiry into what is known as a trusted news initiative, which was set up before COVID-19, but involved coordination between the major legacy media in order to essentially filter out information which was deemed to be inaccurate or misinformation. So we have a pretty unprecedented level of organization and coordination, I think, with COVID-19 that we can see. This is also at this point now translating into what can be described as an architecture for a systematically censored public sphere. We're seeing the emergence of online safety legislation across multiple jurisdictions across liberal democracies. This here is the online safety bill in the UK. And a number of these, certainly in the European Union, the Digital Services Act, but also to an extent, it looks like with the online safety bill in the UK, you have an integration of fact-checking and disinformation into these online safety bills. And it will allow for essentially sort of legal control over social media companies or legal inducements, requirements, etc., which will encourage the filtering out of what is defined as disinformation. So this is where we are now, becoming quite a major industry, an industry aimed at counter-disinformation industry, or as Taibbi and fellow researchers argue, a counter-disinformation complex, obviously drawing upon the military-industrial complex idea. So a lot of propaganda, a lot of promotional authorities' viewpoints, and extensive organization, coordination, and now sort of blending or bleeding into legislative developments, which we're seeing at the moment. Now, underpinning this drive towards controlling misinformation, this drive, this desire to deal with the disinformation pandemic and so on, are a number of assumptions which I'm going to sort of run through to a case study to argue why these are flawed. But just first of all, these underpinning assumptions are that the problem of dismiss malinformation lies primarily with challenges, and I'm drawing upon Gary Wolffeld's classic media and political contest model from the 90s there, where he sort of differentiates between challenges and authorities and so on. And challengers are the non-elite groups who are trying to question what powerful actors are doing. Authorities are obviously the other side of the field in that. But clearly the assumption is that the problem lies with challengers. It assumes also that authorities are right, are correct, have a privileged access to what is the truth in any given situation. And therefore, their viewpoints should be prioritized. And anything that is coming from non-authoritative voices, which is defined as disinformation, must be wrong. And this is also leading to the legitimation of censorship under the guise of the harm concept, linking the notion of malinformation with the idea of it able to cause real world harm to people. And so these are essentially the three assumptions underpinning what we're seeing emerge at this point in time with these drives to control the information environment. Now, the problem with all of this, and this is, as I say, it was running before COVID-19, but it's intensified during COVID-19 and it's now rolling on. The problem with this is that if we go back, if we take a key case study from the COVID-19 experience, it raises some substantial questions about those underlying assumptions. And the case study is this, which I'll talk everybody through in the remainder of the presentation. The Great Barrington Declaration was drafted by a number of leading experts, epidemiologists, including Jay Bhattacharya from Stanford, Martin Kulldorff from Harvard, and Sunetra Gupta from Oxford were the most prominent names associated with this. And this declaration, which was put out in the autumn of 2020 after the first round of lockdowns, advocated essentially for what they described as a focused protection program. They argued that the way of dealing with the COVID-19 issue was not to proceed with nation or population-wide lockdowns, but to make sure that vulnerable populations, such as elderly, should be protected, and that anything beyond that would cause more harm than good to society and to people in general. Now, what happened when these scientists issued this declaration? As became known, I think it was about a year ago, Francis Collins, head of the NIH in the US, emailed Anthony Fauci there, you can see it in the bottom left-hand corner, and referred to this declaration as having emerged from three fringe epidemiologists, and they asked for a quick and devastating takedown of its premises, not irrational engagement with the arguments which were being made, or a suggestion that perhaps there should be an academic conference to evaluate the arguments which were being put forward to challenge official policy during COVID-19. The response was to have it shot down. And this is pretty much what happened with the Great Barrington Declaration. There were smear campaigns initiated. Sunetra Gupta, for example, was described as a conspiracy theorist in the United Kingdom for having raised the questions that she was raising. And to all intents and purposes, it flipped into the censorship regimes, which you could see with the agreements with big tech and with broadcast regulators and so on. So it was effectively censored, and the academics involved were smeared. And I think some of them suffering problems with their employment, I think was the case with Martin Kulldorff, who I'm not entirely sure on that. But of course, what has happened with the Great Barrington Declaration is that to a very large number of academics and scholars, they have been vindicated by events. Collateral Global is a think tank established by Sunetra Gupta and others associated with the Great Barrington Declaration, which has been carrying out extensive research into the consequences of the lockdown. And these scientists are arguing that they have been vindicated by events. I'm not necessarily directly passing judgment on that myself here, but I'm just saying that it's they are not sitting at this point saying, well, we were wrong to have issued the Great Barrington Declaration because it turned out that the authorities had the right response. They're arguing, and fairly fully and profusely, that they have been vindicated, that the strategies that were pursued by the authorities from the World Health Organization down to governments was incorrect and wrong, and they've been proven by events. And there is a very good article here by Kevin Bardosh, and this was commissioned by the Great Barrington Declaration, but this is a meta review of a wide range of studies into lockdown harms. And you can see the conclusions there highlighted from this paper, which Kevin has just produced, talking about rise in COVID excess mortality, mental health deterioration, child abuse, domestic violence, widening global inequality, the list goes on. So the basic arguments made in the Great Barrington Declaration that focused protection, not locking down whole societies, was the more sensible strategy, seems to have been proven by the level of damage which can now be documented and has been documented across multiple studies. And the Great Barrington Declaration team are so convinced that they have been vindicated by events that we now have legal action being pursued against the White House for their collusion with big tech to censor the Great Barrington Declaration. And as Jay Bastiaya provocatively stated, in this case, because the censored scientists turn out to be right in terms of the correct response, according to him, he believes that the censorship involved in this case killed people ultimately. Censorship kills science, and in this case, it killed people, he said. This just brings us to sort of perhaps coming to my closing point. John Stuart Mill, Rational Debate 101, opinion, any attempt to suppress an opinion by authority, which is what all of the censorship regimes I've been describing effectively do, makes the erroneous assumption of infallibility that authorities are right, and then that justifies their censorship. And you can argue that the Great Barrington Declaration case shows how correct John Stuart Mill is on this. They turned out to be correct. They were censored. The authorities assumed they were right, but they weren't right at all. So this is runs against basic concepts of rational debate and open debate and so on. So this shouldn't be complicated, but it apparently is a point which needs to be reiterated to a very large number of people who believe that censorship of disinformation, defining information as disinformation and having it censored is the way to go. Concluding points in my last 30 seconds, minute. I think what we learned from COVID-19 in the broadest sense, and Great Barrington Declaration is not a sideshow, it was a major initiative by major scientists which was censored and appears to have been vindicated by events, is that the assumptions, all the assumptions I listed earlier underpinning the infodemic crisis narrative are fundamentally flawed. Censorship of legitimate scientific opinion is extremely dangerous, as per John Stuart Mill. More broadly, the historical review of political communication literature, which is a background I come from, shows that it is authorities and challengers who are a major source of mis, dis, and malinformation. They have the resources and the incentives, and you see much more distorted communication coming from authorities and influential distorted information than you see coming from the public across social media. And final point, the infodemic and counter disinformation industry in the broadest sense, I think, serve the interests of powerful groups and are fundamentally contrary to established liberal principles regarding rational, scientific and democratic debate. This probably isn't an argument that I should be having to make at this point in time, but unfortunately, given the scale of engagement with the counter disinformation industry by willing academics, unfortunately, it is an argument that we're having to make at this point in time. Thank you very much.
Thank you so much, Piers. I personally very much appreciate your contribution. In fact, academia is an important social agent in producing, in promoting this sort of misinformation censorship complex. They even have a new field now, but that maybe we can elaborate. You can address some of the questions, if any, from the audience. I have some questions myself. So it's a good seg to move on to Manuel, who will elaborate on one of the issues that he is very familiar with. He knows very well how, you sort of, promote mis or malinformation from the pinnacle of authority in a fascinating field that I knew nothing about, in other words, articulated social production of ignorance that Manuel brought to my attention. So Manuel, welcome. And oh, I'm sorry, I'm gonna say that you're a lecturer at the University of Auckland, and you've been researching on these issues for a long time, including environmental issues and how the discourse is managed in that field. Thank you very much, and go ahead.
Thank you, Claudia. Thank you for organizing this session, and I'm just trying to get, there we go.
If I may say just one thing, by the way, for those of you who are watching, we thankfully we're in a virtual room, so we're not taking up anybody's space. So we are very comfortable and happy to stay on a little longer than the official time to field your questions, etc. So, count on maybe say having extra 20 minutes or so to move on with Q&A. Thank you, Manuel.
Great, thank you. Yeah, thank you for organizing this session. It's really important to have these spaces to be able to debate these ideas, the responses that governments pursued with regards to the pandemic, and just having, sorry, I'm not quite sure why the slide just changed. So my name is Manuel Vade. I'm in the Department of Sociology and senior lecturer at, I'm a senior lecturer in the Department of Sociology and Criminology at the University of Auckland in New Zealand. And my presentation is focused on the ideological tactics through which the New Zealand government sought to increase the uptake of mRNA vaccines, which were and are an experimental treatment that received emergency authorization to be able to be marketed without the normal protocols associated with vaccine testing. So the overview of my presentation, I'll speak a little bit about the timeline of the New Zealand case, just to provide some context. And I'll point out some of the ideological tactics that we used. I'll end up focusing on the social production of ignorance regarding the concerns around the vaccines. And I'll mention a couple of key concepts that Claudia alluded to, which was social production of ignorance and attenuation of risk perceptions, which is something I've been working on with regards to pesticides, not necessarily vaccines, but I have been looking at the social production of ignorance around pesticides and other toxicants. And then I'll transition to government means of communications that we use and the communications about the vaccines in particular, and then I'll conclude. And Claudia, what was the final amount that we settled on for time?
Well, we said 15 minutes. We've gone beyond that. So,
okay.
Say tops 20 minutes, so we can wrap up at 4:30 and stay on another 15 or 20 minutes.
Okay.
For
15 minutes will be 15 minutes should be plenty. Okay, so as happened in most of the parts of the world, as a pandemic emerged, the borders were shut down in New Zealand in March 2020. It was a very surreal time. I was teaching medical sociology at the time, and we were talking about issues of power and when they can transcend freedom and individual rights and so on. And as we were seeing other countries close down their borders, students were asking me when and if we should be closing our borders down. It was very, like I said, it was very surreal to be teaching as it was unfolding about this topic. The New Zealand government took a hard and fast approach, which led to vigorous and extensive lockdowns. The lockdowns, the two major lockdowns that occurred, but there were numerous other smaller lockdowns, but two big ones were March 2020 and August 2020. And these were considered to be more rigorous than other parts in the Western world. And just to give you a flavor, I mean, we were allowed to congregate with people in our bubble, but we weren't, it was the only things that were open were gas stations and grocery stores. We were allowed to exercise, to go off for walks, but we always have to maintain strict distancing. Of course, in some other parts of the world that have been underreported, it was a lot more. The restrictions were a lot harder than they were in New Zealand. I like to remind my New Zealand colleagues. The hard and fast approach, the extensive lockdowns and the extensive tracking of cases was credited with New Zealand's low prevalence rate. It was widely discussed as one of the shining cases where we had very low prevalence rates and very low death rates. In March 2021, as part of the ambitions to completely eradicate COVID, there was the beginning of the vaccine rollout. At first, it was just the elderly citizens. And as the government was able to obtain an increasing amount of vaccines, it became available to an increasing segment of the population. By August 19th, vaccines became available to 12 and over for all citizens in New Zealand. At that point, I'll just signal that the messaging started becoming more aggressive. I'll come back to that in a little bit. But as part of a drive to reach a 7% vaccination rate, then in subsequent months, the government moved the goalposts from a 70% vaccination rate target to 90%. Then he moved it again to 95%, and then some aspects of government were pushing a 99% vaccine rate. In early October, as part of the move towards reaching these various targets, Cabinet announced sweeping mandates for staff in education and health. And a lot of people ended up quitting over this in the health sector and in the education sector, which was two sectors that were already suffering from chronic shortages in qualified individuals. So this was highly problematic. Later that month, as part of the push to drive everyone to get vaccinated, Jacinda Ardern came out with a very unscientific approach or statement saying that while there would be medical exemptions, there would only be 100 given throughout the country. And this is not something that one would actually expect if it was science-driven. You would actually establish carefully determined criteria, and everyone meeting those criteria would be given exemptions. And even people with heart conditions were not given the exemptions. And even November that year, the Ministry of Health was denying exemptions for people who had suffered significant injuries, adverse effects, as they call them, from vaccines. So they were very aggressive in this regard. Okay. In terms of the ideological tactics that we use, I mean, there's a lot that could be talked about, and maybe a book could be written about everything that was done. I've written a similar type of book for the pesticides, so I'm envisioning how this could unfold. But there was fear-mongering, obscuring of concerns about the treatments. There was bribery in terms of, I know there's some pretty famous cases in the United States where they were offering first donuts for vaccines. People getting vaccinated would get donuts, and then in some states they were offering guns. In New Zealand, there was also instances of bribery. There was public shaming for those who refused to vaccine, and Jacinda Ardern was actually taking part in the shaming and scapegoating that took place. And then, of course, those threats to livelihood through the workplace mandates that were pursued by the government. Again, there's too much to cover in one session, so my focus here today is just on the obscuring of concerns about treatments, which is something I have a fair bit of experience with regards to toxicants, how the government's obscure concerns. So I did want to say a couple share a couple concepts that kind of guide my thinking around these issues. So there's one of the concepts that I've used is there's a literature on the shaping of risk perceptions, and oftentimes this literature has focused on how activists accentuate risk perceptions, but more lately there's been work that's been done on how powerful entities attenuate risk perceptions, either with their products, as was the case with the salt industry. Marc-Olivier Deplaude, in his 2015 article, talked about how the salt industry in France used a variety of tactics to suppress and obscure the health effects related to the use of salt in food. These tactics included denial, diversion, and undermining or smearing of critics. I've used similar approaches with regards to the government's messaging on pesticides. And my article in 2021 looked at the omission of concerning information, the dismissal and diversion, among other factors. There's also the social production of ignorance literature, has some key points to make about the information that's put out. One is that Proctor, Dr. Proctor's done a lot of work on the tobacco industry, and he's one of the kind of leading figures in the social production of ignorance scholarship. And he's argued that ignorance is not just the absence of knowledge, but it's also the holding of false knowledge that's produced by industry, such as tobacco industries and fossil fuel industries regarding climate change, among others. And then there's, and actually extending on their work, on Proctor and Michael's work, and my book on pesticide use in New Zealand, I've shown how this social production of ignorance can be extended to government agencies and how they control information and suppress information that could be concerning about pesticides and other toxicants. And it's also, and this kind of speaks to that issue, Lindsay McGoey, he's one of the other leading lights in the scholarship, argues that ignorance is more than just the absence of knowledge. It's also a resource that the elite can use to advance their political agendas and to control populations and to control potential backlash. So with that in mind, so government communications, they communicated a variety of information during the pandemic. In one area, they communicated about the virus itself, about prevalence rates, about transmission, about harmfulness, about practices we can pursue to minimize the contagion or the transmission. But then they also communicated information about the vaccine, which, you know, there's a lot of information that was shared, but two large categories are with regards to the safety and the efficacy. I'm not going to touch the efficacy question today, but I'm just going to talk about the safety question. And they communicated in a number of ways. So there was billboards in public spaces early on. This is an example early on in the pandemic, where there was a lot of public service announcements, both on radio and billboard space, as well as the television newscasts or information updates that happen on a weekly basis. This was the director of health, I believe, Ashley Bloomfield, who was largely responsible for at least the tracking part of the government's response, the tracking of transmission. And you can see here their vaccinate is one of the big pushes that they have with regards to how to treat this. One of the things that was unspoken in this push to vaccinate is that the comorbidities that were associated with the transmission and severe or significant symptoms associated with COVID were the elderly and people who had extensive health comorbidities, extensive health problems. So you had the diabetes, being overweight, and there was a series of other things, but that went unmentioned, despite critics within New Zealand really pushing hard that we needed to have a larger conversation about the political economy of health and how that mediates the transmission of the disease, not just COVID, but other diseases as well. This was seen by some, the pandemic was seen as some as an opportunity to really rethink how we handle health And unfortunately, the government missed that opportunity. So the messaging consistently portrayed the vaccines as completely safe, and this was in the public service announcements and the television broadcasts, where there was never an opportunity missed to say that the vaccines were completely safe. And Jacinda Ardern, and she was one of the big proponents of this message, or disseminators of this message. And one of her quotes is, "Anyone who doesn't take up effective and trusted and safe vaccines when they become available, there'll be a risk to them." Originally, it was posed as a risk to the individuals, but as the pandemic wore on, as the lockdowns wore on, and as there was this drive to attain higher and higher vaccination rates, the rhetoric became sharper and sharper, and it led into scapegoating and blaming for the continued on the people who did not want to take vaccines as the cause of the continuation of this pandemic. In this vaccine is completely safe discussion, there's no discussion of vaccine-related injuries that are reported in vaccine injury databases. There are numerous databases around the world that report on vaccine injuries, not just the COVID vaccines, but all vaccines. All vaccines have adverse effects of some level. Some are minor, some are more major. Some have led to the withdrawal of certain vaccines in certain countries, but there's no discussion of this. And some of the vaccine databases, for those of you who are interested, is the US vaccine database, various. There's also UK has a yellow card, Norwegian Medicines Agency, which is, I think, have been really effective. And then there's also the World Health Organization's VigiAccess database. Some of the things that occurred or emerged as health issues associated with the vaccines, the COVID vaccines, were myocarditis, pericarditis, which are heart-related issues, stroke, cardiac events, paralysis, liver failure, Bell's palsy, epileptic seizures, inflammation. And this is just a small subset. I mean, if you go to VAERS, you plug in, let's say, the Pfizer vaccine, it'll pull out over 100 different adverse health effects, and it'll give you the proportion. Now, some people will say, well, look, you can't really rely on the vaccine database because the CDC reports the data without evaluating the cases on whether there was actually a causal relationship. Be that as it may, there's also one of the problems on the flip side with these systems is that they're passive reporting systems. They're not tracking down all issues associated with the vaccines. And so that leads to significant underreporting. And then doctors who are often the ones doing the reporting, they have a lot of bureaucratic obstacles that prevent the reporting of these, which leads to also significant underreporting. There was in the government's messaging that the vaccine was completely safe. There's no discussion of public health reports that emerged from other countries, including, for example, the health report that came from Public Health Agency of Ontario, where they're messaging significant concerns about boys and young men having an increased risk of myocarditis related to the Pfizer vaccine. This was completely absent, completely whited out by the government. There's absolutely no nuance whatsoever in the messaging. There's no discussion of the medical literature that pointed to shortcomings associated with the vaccines, and this included a widely known article from the British Medical Journal that actually talked about the falsification of data that occurred at the Pfizer vaccine testing. And Piers' presentation really speaks to the issue. I think there's a good overlap in that there's a lot of information that was, they tried to censor at the level of even the journals, but if somehow information got through, the government's absolutely censored it. And that was no nuance in their discussion of vaccine injuries. I know I'm out of time. So I think the major point in this is that the assumption of infallibility, I think, is a really key concept that Piers talked about, which is really applicable here. The people who were in charge of the response and the messaging around the response really operated with this assumption of infallibility, which led to these very black and white decisions that impacted people's not just their bodily autonomy with regards to deciding whether or not they were going to take an experimental treatment, but it also had impacts on the family dynamics, because there's all sorts of family ruptures that families here are still having to deal with certain parts of the family insisting that other members take the vaccine or not see them at all. And then there's the question of livelihood. I mean, these decisions, how governments approach, especially if it leads to mandates where everyone must get this, had a huge impact. And I'll just kind of say one last thing. It'll be really interesting to see the fallout that'll happen in the United States, of all places, with regards to the mandates that would put on military personnel. Following the Gulf War, when there was a mandate during the Gulf War for all the US servicemen to have the vaccine A, which was eventually the vaccine for anthrax, that was associated with a whole host of Gulf War syndrome symptoms. There's a lot of lawsuits that were filed that the servicemen won against the government. And a lot of people, high-ranking officials in the US military, thought that that would never happen again. And to their horror, saw it replay itself during the COVID pandemic. So pay close attention to those lawsuits that will be trickling through. It'll be really interesting to see what information comes out of that and what the judges and juries decide. So thank you for your time, and I look forward to the Q&A.
Thank you very much, Manuel. Wow. Okay, so we have a couple of questions. I hope we get another, maybe another couple. I'm gonna first give the floor to Sydney first, because it's the first question is directed to her. And also because you might have to leave a little earlier. But I mean, I see a lot of connections, and I have many questions myself. So the question is from Ursula, and maybe I can get a little bit of advice from Sherry if I should do something about Ursula, like allow her to speak or elaborate. But anyway, while I get your answer, Sherry, let me just read it. This is heartbreaking research, Sydney. How are researchers like you coping with the emotional trauma of your fieldwork, to do the research, and the ongoing dismissal by the authorities of its value?
Yeah, thanks for this question. I think it hits on, I think the entire sector, to be honest, the entire homelessness sector, the homelessness service sector, and those who access it are not coping. I think that for so long they've been in a survival mode where it's just a matter of going through the motions and doing the best that we can to manage what has happened, the absolute destruction that has happened within the sector, the impossible choices that people have had to make on a regular basis because there is not a good choice. And it's been horrible to hear about the death, the isolation, the overdose crisis, everything that has happened. It's been horrible to hear. It's been horrible to see. I'm sure it's been horrible to experience. So I would say that, yeah, like that is the situation, unfortunately, is that it's quite bleak. It's all traumatic. There's nothing good that is coming out of it. We have seen people band together and care, and that is really lovely to see. But it's a hope that people who have experienced such devastation throughout the pandemic will not be forgotten now that we're moving out of it, right? And so that this won't just kind of fade into the background and then never be seen again or never be thought about again. But yeah, it's devastation, honestly.
What about your own response? Because I think that Ursula was interested in how do you deal with, actually doing the research?
Well, it's been an important project. I think that it's you have to learn from it, and so that I think is the most important thing, is that this is an opportunity to learn from what has happened and to make to hope that we can bring forward better emergency responses in the future, because there will be continued emergencies. We know that this is the reality of things. And so to work towards planning and to provide some sort of potential planning response is hopeful in at least a minimal sense. But it's true, it's really hard to deal with the dismissal of it and the lack of attention that has been it's been continuous this whole time. So
thank you, Sydney. I wonder whether others have something to add, maybe from your own perspective. I was thinking that what the response has been is premised on misinformation that I personally think is of value, and that in the name of health, it actually has crushed the health of people in a variety of social groups, right? So maybe Piers or any of the other two presenters wants to expand on this point. We have one more question, and that's about it.
Sorry, is this to respond to the first question? The emotional
right. I mean, just
trauma.
to elaborate, because the response was made under several assumptions, right, that were made by the authorities, right? And the assumptions were in order to protect us all, right? To keep you safe. We're going to do this, that, and the other thing. As it turns out, what I'm saying is that the assumptions were to be a scientific grounding, but also the results are transparently harmful to health, which is precisely the reasoning upon which these measures were implemented, right? So given your work on the business of infodemics and whatnot, you might have, but otherwise we can move on to a question that is directed to you.
No, I mean, okay, this broad question of emotional trauma, I mean, for academics researching it, that's one thing. I mean, I was at the conference over the weekend in Portugal, which was, primarily aimed at behavioral scientists and psychologists, actually primarily psychologists, but looking at propaganda and the impact on mental health of the population. And I mean, all of the strategies pursued, both informational but also material, or it's mandating lockdowns. I mean, there's a pretty broad consensus at that conference that it's had an overwhelmingly negative impact upon the mental health, and some pretty horrendous figures from people working with children, for example, in terms of increase in panic attacks, suicide, depression, etc. All in a way quite predictable. I think, when you combine an information campaign or a propaganda campaign, which involves making people very, very fearful and then shaming them and then subjecting them to quite extraordinary restrictions, it has predictable effects. I think following on from that now with this question of, as you say, the question marks over this scientific justification now are very big, and there seems to be quite a lot of dissent even within the mainstream academia on these issues now. I mean, what that's going to do for everybody, well, I think as you've probably heard me talking in other settings, I think this is part of much bigger processes at work, and we are, in a sense, in a period of crisis, not a health issue crisis, and in a broader crisis, and this links into that. But this is a very tough time, I think, for the psychological traumatic impact of what's happened. And as far as I can see from what I've heard, the figures look pretty grim, from whether it's excess mortality or health, longevity, etc.
So let me ask you the question then by Ursula too, and I invite others to put in their own. I'm sure that people have questions, and they could be challenges too. We're happy to take challenges, because some of the things you may have heard here are not the most popular, the most sort of widespread beliefs. And that's fine too, because we're not going to debate here where are we going to do that. So the question for Piers is, somebody who obviously supports, agrees with you, Piers, do you think that academia is salvageable after this catastrophe of public health? That is Ursula asking that. Do we need to rethink and go back maybe to grassroots unbiased education? And maybe there you can elaborate, because I've read your work on, propaganda more generally as well beyond the realm of the media. I've always been, convinced that the leading propagandists are not necessarily the media, but major social institutions that we're all part of, right? So maybe you can elaborate on that. The question by Ursula is it salvageable? But maybe you can expand on that as well.
Yeah, I've become increasingly skeptical about whether existing institutions can be salvaged in the sense that it's a matter of a gentle course correction. I think that COVID-19, whether it's what has emerged in terms of, as I was talking about with the counter disinformation industry, this kind of the role of the communications academics, many of them colleagues or former colleagues of mine, getting drawn into that industry in their cooperation with government, which should be understood as a problem, but it's not by many of them. Whether it's that or the issues of the big pharma and the regulatory capture, which is quite well documented now. I think that this points to pretty fundamental problems in a lot of our institutions. And as you say, it's not just a question of the media, it's a question of academia, NGOs, and so on. And so I think, broadly, I think that COVID does indicate that there are, or perhaps another way of putting it is it confirms that there are very big problems with many of our institutions. And really, at this point, I think we're looking at really public things such as public awareness, I think, is very important because that can create pressure as well as sort of more formal sort of political engagement and so on. But I think that's public awareness is very important. I think there are signs of this because, say if you look at the issues surrounding the mainstream media, trust in the mainstream media for a number of reasons, but very much to do with COVID-19 is at historic lows across Western democracies, certainly in the US, certainly in the UK. And, when you're looking at it going for about sort of 70% high trust ratings in the 60s for US network news, etc. And it's right down to a very low figure now. So people have lost trust in the media, but the same goes for medicine. And ultimately, I think because there's been a lack of pushback from most mainstream academia, there's a loss of trust in that institution as well. So broadly, I think things are salvageable in the sense that you can fix anything. It's just that this is a very big fix that needs to get underway. Yeah, it's going to be a big challenge, but this is a bigger, wider political challenge. I think we are broadly in the sort of the biggest geopolitical sense. We're in a phase of transition. West is in varying degrees of crisis, as we can see, politically and with mobilization, etc. And that indicates that lots of things are going to have to be changed in a very significant way, not just academia.
Let me pose a question then to bring everyone into the conversation, the of you, as you make a point about the decrease in trust in the media, but also in organized medicine. And the media and organized medicine, as we have seen, as well as, say, the WHO, they frame this as a trust in science, as a distrust in science. So apparently we're all stupid. We're not scientific enough. And for them, the way they frame it is that trusting them means to trust science. So when you trust their communications, and you're an expert in communication, political communication, right? When you distrust their communications, the problem is framed in science. And then we have this mass corporate production of, the misinformation industry, dedicated to, challenging anything that doesn't fit the official narrative, so as to bring people back to science, right? Which is really not back to science, because science was never about censoring and smashing your opponent, right? That's the box match, but not science. So how do you folks in your own areas of research, deal with this tension that maybe the message you're trying to put out, if it doesn't fit, is thrown out? And that's a question for all the presenters. This is a question that really inspired me to propose this session. How do you deal with that kind of attack, or with that problem, right? You open your mouth, boom, here comes the misinformation censorship complex, and you're out unless you toe the line. So, and then the crisis of academia that Ursula pointed to, and then the emotional impact of dealing with these issues for all of us. What do you make of that? How do you face it? Does that make sense? Manuel, you've been quiet. I know you're tired, but maybe you can make a contribution, because we have an international audience here, which is an interesting feature as well. And maybe we'll close with that after you elaborate. Or alternative would be to just close with some thought about what you see your work moving forward.
What I'm seeing here in Hungary and Budapest is people have been expressing their regrets about obtaining this inoculation, and expressing that they have become ill in certain ways, but they're not necessarily making connections between their illnesses and the inoculation. So I think that still needs to kind of be more clarified or made more obvious. But I'm seeing a bit more hope here in this part of the world about discussions and possibilities of opening up more light and information about what the scientific narrative has been promoting and making a propaganda.
Well, that's encouraging. I think that we can anticipate what the answer to that resistance will be. Accusations of being a right-winger, which is presumably bad by definition, right? Because this corporate endeavor has appropriated, the sort of meaning, what it is to be left or what it is to be a good person. We've heard a lot of moralizing coming from Sydney too, right? Who is a good person based on whatever their living practices are, etc., right? But it's encouraging to see some resistance and response. Piers, Manuel, Sydney.
Yeah, I mean, if no one else is going to come in, I'll just mean my final comments would be we're certainly in a period where I was in mainstream academia for 20-25 years, including my PhD. Certainly the last 3 years, the intensity of pressure on people to self-censor, and as a co-optation of academia into wider power structures is never seen at this level before. We've always had these pressures, but it's certainly become much more intense. So, there's a kind of an issue there of, what are we here to do as academics within institutions? It is there to think critically and to challenge power, and trying to keep that in mind. And so on, whilst one navigates the pressures, I think it is very, very important, because, out there, people do rely upon academics to, you know, to stand up and speak the truth and so on, and to do the research which challenges power, etc., gets to the truth. And you know, academics can play a very important role in that. So it's important to keep those, I think, those fundamentals in mind. But this is unprecedented levels of I think pressure and a sort of institutional failure breakdown that we're seeing at the moment.
There's a question actually that I missed because I believe it was in the chat, and now Sherry's alerting me that I'd like to use this line of thought. I can't see the name. How stigma against people with disabilities who opted out of traditional, though occasionally paternalistic treatment options, like what you were saying, Agnes, etc., you know, but or people who simply, you know, think, you know what, let me wait a bit because this is so new and I don't know what's going to happen in, you know, 5 years, and by the way, I'm fine. So but I'm not sure I can sort of understand or articulate the question. I think it's in the webinar chat, and I'm not sure how to, you know, how to ask people an intelligible question. It has to do with probably what the person is trying to say, the implications for people not homeless, but, you know, of a diversity of needs, as all human beings are, right? We're not just cut out with the same pair of scissors. So we have different needs. So how would they deal with that if this is kind of a top-down imposed response and nobody is allowed to not toe the line, right?
Yeah, I mean, I guess, I mean, the general issue, as many of the panelists have been on this in this session, is, you know, the importance of looking at the impact of the policies. Is this kind of stuff that Panda is trying to develop and so on, looking at, for example, you know, the role of behavioral scientists and nudging and so on, and the ethics of that, etc. But also, as with global collateral, looking at the actual impact, the real world impact of the policies and so on. You know, both at the broad level, but also fine-grained and detail is an extremely important thing to do, because it needs to be documented what has happened over the last few years, certainly. So it's a good area to pursue, definitely.
Okay, so it looks like the audience is winding down. So I'm going to thank everyone for spending such a long time with us, a little longer than predicted, and I believe that eventually will be made available. So thank you very much, wherever in the world you are, and hopefully I'll get to see some of you at the in-person CSA meeting this upcoming week. Thanks a lot. Have a great rest of the day and evening.
Nice to meet you all.